And yeah, thank you so much for coming this morning.
Yes. All right. Good morning, everyone. Thanks so much for having me here. I actually really consider this an honor to be giving one of these talks. I've been doing it for over a decade now, and it's just, you're all fresh, and to feel like this is something that's high yield enough to be called back to do this every year. But also, this is something you're going to be every call night. You're going to get something like this, is what it feels like. As long as you have a patient on telemetry, this is going to happen. In terms of disclosures, I write for Up to Date. So our goals today is we're going to try and learn the basics of ECG interpretation of arrhythmias, determine the best management of those arrhythmias,
I'm just going to turn my camera on a second.
understand the role of anticoagulation around cardioversion, and then recognize different types of bradycardia on EKG. So what do you do if you're called for an arrhythmia? So the first thing is assuming the person's on telemetry, check it yourself. All right, we have really good teletechs, and we have good nursing also, although I think our teletechs, I learned from them even, because I think, especially at Mod Lake, they're really good. So check the telemetry yourself. Don't take anyone else's word for it. At the very least, maybe you'll learn something. And then if the arrhythmia is sustained, it's always best to get an EKG, unless there's no pulse. And then if there's no pulse, please call a code. So how do I approach an EKG? Let's just start with the basics here. So I just first eyeball it. I just do a quick look over it and be like, is there anything that's striking me as super normal, super abnormal, and just sort of like the quick gestalt. And then I go through and I do this pretty much the same way that I learned when I was in medical school. So I go through and I say, all right, what's the rate? What's the rhythm? What's the axis? What's the intervals? What do the P waves look like? Do they look like they're sinus, or do they look like they're coming from someone else? Can you see P waves, or is it some rhythm that doesn't have P waves? What do the QRSs look like? Is there a bundle branch block? The STs and T waves. So is there ST elevation? Is there ST depression? Do the T waves look upright in the leads that they're supposed to look? And then I describe and I diagnose. So describe would be that there is a irregular, narrow complex tachycardia with ST elevations in leads 1, AVL, and V5 and V6, and ST depressions in the inferior leads. And then I would diagnose and say, all right, I think this person is having rapid AFib with a lateral ST elevation MI, something like that. So that's my way to really be organized so I don't miss something. And the important thing is to look at the entire EKG, look at every lead, and look at every beat. And it's important to do that, because if you just look at one lead, you're going to get an EKG like this. So I don't think we have a poll on this one, but you look at this lead and you say, what's the rhythm? And I would look at that and be like, I don't know. But when you put it in context and you say, all right, look, here's the rhythm strip that was associated with this. And if you just look at V1, you're like, I don't know. But here it is when you get all 12 leads, and especially when you look in the rest of the precordium, what you can see is this is sinus tach. I think we're faster than 100 beats a minute here. So sinus tach, the PR interval is a little bit long. So there's first degree AV block and there's a left bundle branch block. But if you just look at V1, the size of the P wave and the size of the QRS complex are essentially the same because they have left atrial enlargement. So you really want to be looking at every lead and every beat. You don't want to miss something that's like at the very end that you may overlook, that may give you the hint or the answer about what is going on. I also love this, even like if you look in lead 2 here, the P wave is bigger than the QRS. So if you just had lead 2, you wouldn't know which one is the P wave and which is the QRS. So 12 leads are better than 1. How I approach arrhythmias. So first question is, do you have calipers? And I am an electrophysiologist, so of course the answer is that I have calipers. But it is the best way that you're going to be able to manage your arrhythmias. I recognize that we do not I don't wear a white coat anymore, and many of you may not, so you may not have the pockets to be carrying these things, but if you have calipers, it's always more helpful. But otherwise, as you're approaching the EKG, first question is, are there P waves? And if you see, well, really, it's are there QRS complexes, but I'm going to assume there is for this, unless you're coding them. So it's, are there P waves? And then, are the P waves and the QRS complexes regular? Or is there an irregularity to the pattern? Is the QRS narrow or wide? Are there more P waves and QRSs? Are there an equal number of Ps and QRSs? Or are there fewer P waves and QRSs? And then lastly, is there a constant relationship between the P waves and the QRSs? So is the PR interval the same? Does it lengthen, which would be consistent with something like Wenckebach, let's say? Or does it shorten, which you'll see sometimes in people who have certain types of SVT? So when I'm thinking about tachycardia, so when I went through that schema there a second ago, or that list of questions, really the two, when you're talking about tachycardias that are the most important, is the rhythm regular or irregular, and is it narrow or wide? So if you can at least describe it and just say it is a regular narrow complex tachycardia, then you can put it in one of these boxes. All right, so the regular narrow complex tachycardia is by far the number one that you will see is sinus tachycardia. Atrial flutter is the most common pathologic one. Not that sinus tach isn't pathologic, but let's just say non-sinus one. And then you have your paroxysmal SVTs. So there's AVNRT, AVRT, atrial tachycardia, and very rarely junctional tachycardia. So those are going to be your regular narrow complex tachycardias. There's not a huge differential with them. Your irregular ones, by far the most common irregular narrow complex rhythm is going to be AFib. Or tachycardia will be AFib, but multifocal atrial tachycardia, MAT, that you see in people with pulmonary disease more commonly. Just frequent PACs. So if someone's having a lot of PACs, it's going to be irregular. And then very rarely you can have some of these other rhythms that will be irregular and narrow complex, SVTs, and someone's going sinus tach with Wenckebach, let's say. Your wide complex tachycardias may get you more, or typically get you more concerned. And your regular one, the one you're most worried about, is monomorphic VT. But people who have WPW, Wolff Parkinson White, will have, or can have this type of AVRT, where it's going down the bypass pathway and then back up the AV node backwards. And then any type of SVT where there's like a bundle branch block. So that's pretty common for your regular wide complex tachycardia. It's probably the most common. And then rarely someone who's got bypass pathway. That's Wolff Parkinson White, or if they have a pacemaker. Like, for instance, if you have someone who's got sinus tach and they're ventricularly pacing, it's going to be a regular wide complex tachycardia. And then the irregular wides, so polymorphic VT, VF, those are the ones we get worried about. But then anything that's up in this list above of the irregular narrow complex ones, if they have, again, a bundle branch block or rarely a bypass pathway or pacing. By the way, I did put my slides up on MedHub as a PDF, and I don't know if you guys can download those, but otherwise I can give them to Emily. Actually, I think she has one that's set already, but I'm happy to have you guys have these. All right, so if we're looking at the narrow complex tachycardia, so we're going to start here. So a 73-year-old woman is admitted with pneumonia, and she reports acute onset of shortness of breath when she's in the hospital. And this is our 12 lead, and we're going to do a poll question in a second. And the question is going to be, what's the rhythm? And I'll give you some options here. So here's a single lead. I know we said shouldn't do that, but you should be able to get this answer off of that. So what does this EKG show? And hopefully we're opening the poll. Okay.
Is it? Are you seeing it?
I'm not seeing it.
Okay.
Yeah,
Sorry,
neither am I.
guys. Man, hold on. No one's seeing it yet.
Not this time.
Oh no. Sorry, everyone. Let me just try again.
And if we can't make it work, that's totally fine. I wonder. Oh. For what it's worth, when I pull it up polls on my thing, I have that question that we did from that other person's.
Oh, let me see. That is the problem. There we go. Okay, thank you. That was the problem. Okay, this should work now.
Yes.
Okay, thanks everyone. All right, we got a good response.
All right, let's see it then. Good. All right, 92% of you. Great job. So this is AFib. All right, it is irregular. It is narrow complex. And when I look at this, there's no really clear, consistent P wave. Do I have? So there's this that same EKG. So there's no clear, consistent P wave as I'm looking at this. There's a lot of irregularity to it, and there's some things where you say, like, I don't know, is this like a little P wave thing here at the bottom, and maybe there's a P wave there, but you just don't see that consistent pattern to something that looks the same as a P wave before every beat. So this is AFib. There's this undulating baseline associated with it, and it's a narrow complex, borderline tachycardic here. All right, let's do case 2. So a 61-year-old male comes to the ER with palpitations. Heart rate is 155. Blood pressure is normal. And this is his EKG. So I'll give you a sec to look at that there, and then we're going to ask the question. Same thing of what's the rhythm. So what does this EKG show? Yep, it's working, Emily. All right, maybe we can close it out there and get going. All right. Good, I like that. I like that it's a smattering here. Because what I would say is I think it's tough. It's tough on this one lead or even on that 12 lead to tell, but I'll tell you the answer is atrial flutter. And then you're going to say to me, how can you tell that? So if I ever have anyone who has a heart rate that's coming in at about 150 beats a minute, I am thinking in my head, could this be atrial flutter? So atrial flutter very commonly is going to be at about 150 beats a minute. And I'm approaching this EKG and I'm saying, hey, look, this is a narrow, complex, regular tachycardia. And whenever I see a ST segment that is downsloping here in the inferior leads and it's going at 150 beats a minute, that's at least sitting there in my head, could this be atrial flutter? But I'll say, you can't say for sure based on this alone. You got to do something to slow the heart rate down. And it's a lot easier to tell. So this is a different patient, but here it is. When the heart rate is slower, you have in the inferior leads this negative sawtooth pattern that's going through here. So it's a lot easier to tell when the heart rate is slower. On the one before, it is challenging. And so you want to do things that we'll get to in a little bit to try and make it slower. Sometimes you'll get an EKG like this, which, people have various names for it. They might call it flubber, and where it's like sort of looks like flutter, sort of looks like fib, but we would call this fib. Doesn't really matter from your point of view in terms of management. It matters a little bit more to me as an electrophysiologist in terms of what I'm going to do. But you can sometimes have AFib waves that are really big. Like look in V1 here, how big those AFib waves are. They're pretty chunky there. So how are you going to manage it? So you're called in the middle of the night and this person has gone into AFib or flutter. First question is the patient hemodynamically stable? So what's their blood pressure? And then how are they feeling? Are they having heart failure symptoms? Are they starting to develop pulmonary edema? Are they starting to develop mental status changes? Is there suggestion of ischemia because they're having chest pain or angina? So if they are having symptoms which are concerning to you, and especially if there's hypotension, then you want to be cardioverting them. However, please don't be shocking anyone while they're awake. If you're going to get to the point where you have to cardiovert someone, please have anesthesia there because it really hurts to be shocked. So let's say the person is stable. All right, they've gone into AFib. Most episodes will spontaneously convert within 24 hours. So the question really is, do you need to do something? And if someone's having symptoms, then yeah, you want to try and make someone feel better. So if they're mildly or moderately symptomatic, yes, severely symptomatic would be the hypotension type thing. And if it's going fast, you probably want to do something. So typically what our goal heart rate is less than 110 beats a minute. But otherwise, if they're not feeling it and their heart rate is 100, and especially if they have a history of known AFib, you probably don't need to do anything. And it's one of the things that you're going to learn throughout these next few years is there's this sense of like, if something happens, I have to do something. But sometimes it's okay to not do something, and that's the right choice. So if I have a patient who goes into AFib, especially if they have a known history of AFib, they're not symptomatic, their heart rate is less than 110, I don't do anything about it. Don't check a troponin, please, if you have someone who goes into AFib, unless they're having symptoms that makes you think that they're also having an acute coronary syndrome of some sort. All right, there's no indication for troponin. Ischemia super rarely causes AFib, but it doesn't cause AFib unless there's some other sort of symptom or something else suggestive. I'm going to just do a brief aside, because this is one of the QI things that we're trying to work on, which is if you see someone who you've checked a troponin for some reason, but they don't have anything else to suggest that they're having an MI. So let's just say you have someone who has a pneumonia and you check a troponin and it's a little bit elevated. Please don't call it an NSTEMI. That's called a myocardial injury. Please document that appropriately and call it myocardial injury, unless there's something that really makes you think that they've had an MI, like they've had new wall motion changes on an echo, or they're having new Q waves on an EKG, because it really dings us on quality metrics if you call someone having an MI, but it's actually a myocardial injury, and then they say, how come they're not on an aspirin? How come they're not on a beta blocker? How come they're not on a statin? And all these other things that you would want to do. So that's a whole separate thing, but I'm throwing it in here because it's a QI project we're working on. So if you do want to do something, the most common thing that you're going to end up doing is giving IV diltiazem. And you'll usually use a bolus somewhere between 5 and 20 milligrams IV, and then you'll start a drip usually at 5, and it can be titrated up to 20 milligrams an hour. And diltiazem is usually the drug that's preferentially used from an IV form, just because it can be given on the floor and you don't need to be in an ICU. So in an ICU, you might want to use esmolol instead, but you can't do that on the floor. You can give a few boluses of metoprolol IV if you want, but that's not going to last forever. That's just sort of a bridge. Or you might say, hey, look, let's just manage them with PO, either DILT or verapamil, metope, atenolol. There's really not much of a role for digoxin, especially because it takes several days to kick in. And it probably doesn't work super well, and it may be toxic in certain people. So if you feel like you need to do something for rate control, diltiazem IV is going to be the main thing that you're going to go to. If you're going to do rhythm control, if you decide you want to try and convert someone, amiodarone is the drug that you're going to use 99% of the time. You'll give an IV bolus of 150 milligrams, and then you'll start a drip, usually a mg a minute for 6 hours, and then 0.5 mgs a minute for 18 hours, or longer, depending on the situation. Really, someone should have a central line if you're going to do it like a PICC line or something else. Some of the floors actually have rules about whether you can give it through a central line, because you can get this thrombophlebitis in like this patient that I had. That could be tender and uncomfortable and such. I will sometimes use either flecainide or propafenone or ibutylide, but even most of our cardiologists won't be doing that. It'll be EP that'll be getting involved in those situations. But even that we don't do very often, because if we're going to do rhythm control and amio hasn't worked, we usually will sedate and cardiovert in a more elective fashion. This comes up a lot, this question about anticoagulation and cardioversion for AFib, so DC cardioversion, direct current cardioversion. So we know that there's an increased risk of stroke after a cardioversion, and it is the act of cardioverting someone that the electricity you're giving, the shock you're giving, increases that risk of stroke above the risk of stroke that would happen if they naturally converted. Because what ends up happening is that you get a dissociation between the electrical signal and the mechanical signal. So you see a P wave, but the atria aren't contracting. And it takes up to 30 days for the atria to fully start contracting again. And that's a time where you can develop a thrombus in the left atrium. So if you're deciding that you need to convert someone, you need to anticoagulate someone, or you have to decide if you want to anticoagulate someone or not. So the rules are, in general, if someone's been in it for over 48 hours, their risk of stroke, of developing a clot, is going to be higher. And so either they need to have 3 weeks of anticoagulation beforehand, And that's either being on apixaban, rivaroxaban, dabigatran, or edoxaban for 3 weeks continuously. 1 or 2 missed doses is probably fine. Warfarin, you need to have a weekly check, or we have to do a transesophageal echo first. If they've been in AFib for over 48 hours and you are going to emergently cardiovert them for some reason, then what you should do is, because you can't get a TE for whatever reason, give a heparin bolus, and then make sure you anticoagulate them for at least 4 weeks. And if it's less than 48 hours, you may not need to anticoagulate them. So if someone is low risk, if you guys know the CHADS2 VAS score, so if they have a score of 1, 0, and it's been less than 48 hours, you probably don't need to anticoagulate them. But if someone's higher risk, mitral stenosis, they have a CHADS2 VAS score of 5, 6, 7, they have hypertrophic cardiomyopathy, they have a prosthetic valve, in that group, then typically you would be saying, we might need to do a cardioversion, or we might need to do a TE because you're worried about it, but you probably would give anticoagulation. But I hope in these situations you're calling cardiology. All right, sinus tachycardia, we'll talk about this. There's no question associated with this. So this is a 30-year-old who's admitted with shortness of breath, and he has a heart rate of 175. Excuse me, she has a heart rate of 175. And so you have to figure out why. All right, sinus tachycardia should be one of the more worrisome rhythms. I worry much more about sinus tachycardia in general than I do AFib. So you're going to just go through, this is not the full list of causes of sinus tachycardia. This is a partial list, which will get you most of them. So fever is going to be really common, / infection, sepsis, some sort of volume depletion, whether that's hemorrhagic or overdiuresis or whatever it is. Hypotension and shock, anemia, anxiety, a PE, MI, heart failure, you'll see it, COPD, and you can read the rest of this list here. So if someone is in sinus tachycardia and you're called about that, in general, we don't treat the heart rate. Figure out what the underlying cause is and treat that. And then the sinus tachycardia, which is a compensatory thing, will fix itself as you have fixed whatever that other problem is. The one situation where it's not true, where we do treat sinus tachycardia, is in the setting of acute MI. And in that situation, you're going to give beta blockers. So usually you'll be doing IV metoprolol. So again, hopefully you'll be calling cardiology if you're in that situation. But again, don't treat sinus tachycardia in general. Try and figure out what the underlying cause is to try and then secondarily treat the sinus tach. All right, case 3. So a 63-year-old is admitted with chest pain to 5 Northeast here at Montlake. And while waiting for stress test the next day, he reports the abrupt onset of palpitations, has some mild chest discomfort, and has a pulse of 150 with a normal blood pressure-ish. And this is his EKG. So here's your question. You can open up a poll. What are you going to do? Are you going to cry? Going to call your senior resident? Are you going to give adenosine, metoprolol? Going to do all of the above? Something else?
We're getting some good, honest answers.
Good. I will tell you, I don't know how your experience so far has been in this first month of yours, but I definitely cried when I was an intern. I had some tough days and some tough nights, and it is a tough year, but you learn so much. All right, look at that. That is a nice smattering. I think any of these is acceptable. Hopefully, if you're going to sit there and cry, which is fine, then you're going to move on to something else. And you don't hit a block with that. So it's in this EKG, you can't tell. You can't tell what's happening. I don't see any P waves. And so I wouldn't know what this rhythm is besides saying it is a regular, narrow, complex tachycardia, and I don't see any P waves, or at least anything that I can clearly say that I reproducibly think are P waves. So we gave adenosine. And the really super important thing is that if you are going to give adenosine, please make sure at the very least that the person is on telemetry, but even better, that you're running a 12-lead EKG continuously, like a rhythm strip here, and then that it's either put in the chart or it's saved in some way, it's scanned into media, something so that we can see it. So in this case, the person got got adenosine, and those arrows there that I put are showing P waves. So when you give adenosine, you block in the AV node. If it terminates the tachycardia, it gives you a sense of whether it's AVNRT or AVRT. But if it doesn't terminate it and you see P waves marching through, that's most consistent with either atrial tachycardia or sinus tachycardia. And so that's really helpful to me. So that's an example. Here's another example of someone who is in SVT. And what's catching my eye when I look at this is, oh, look, there's this little S wave here in lead 2. Maybe that's a P wave that's inverted. And I don't know, something looks a little funny here at the end of this V1. Maybe that is a QRS complex there, but then I don't know, like there's something here in lead 2. Maybe that's a P wave and you see it there, but you don't see it there. So don't quite know what's going on. And in this scenario, when they get adenosine, here it terminates the tachycardia. Please be sure if you're going to give adenosine to anybody that you warn the patient beforehand that I usually tell people you're going to feel awful for about 5 to 10 seconds. You're going to feel like you're dying for about 5 to 10 seconds, and then you're going to feel better. So just give them the heads up. It can be slightly unpleasant. And when I say slightly, I mean moderately unpleasant. But then they'll feel better afterwards. So if you have someone who's in a paroxysmal SVT, so vagal maneuvers are the first thing to do. So Valsalva maneuver. Valsalva, in general, you're going to say, tighten your belly muscles, feel like you're bearing down to have a bowel movement for 5 to 10 seconds. It works best if someone is laying on their back. And if you really want to do it right, you can actually try and lift their legs as they're doing it, which can improve the success of it. People have tried to do things like having someone blow in a syringe also to try and give the right amount of tension in the belly. The other thing you can do is you can do a carotid sinus massage. So find the pulse, 5 to 10 seconds of a circular motion. People have talked about listen first to make sure there's no bruits there. It probably doesn't matter, but there's no harm in doing it. Don't do both carotids at the same time. Just do one at a time. We used to talk about also doing like an ocular pressure, but there's reports of people fracturing their globe, and so we don't really recommend that anymore. If you're going to do adenosine, 6 milligrams first, 12 milligrams next, central line if possible, and you really want to push it fast and flush it fast. Sometimes I will go up to 18 milligrams. You do run the risk of bronchospasm if you give too high a dose of adenosine. And let's say someone is in SVT and adenosine is not working. You can use beta blockers and calcium channel blockers. You can do some IV metope. You can put someone on a DILT drip or a DILT push. And that can work also. I have some patients who will say, or who have said that they don't want to have an ablation, but episodes are infrequent. They've gotten adenosine. They hate it. They never want to get adenosine again. That I've given them a note to give to an ER doc that says, don't give adenosine, give diltiazem instead. And just if someone has a history of Wolff, Parkinson, White, you can still use beta blockers. And we'll skip over this. And cardioversion is what you can do if you have someone who's recalcitrant, especially if they are hypotensive with it. But it's pretty unusual to need to cardiovert SVT. All right, 2 patients, same diagnosis here. So on the top one, so this is a telemetry strip. This is 2 different EKG leads, and you can see things change here. On the bottom one here, this is an EKG lead, and then this is a pulse ox waveform. And so the question for these 2 is, what is the diagnosis? All of my questions, by the way, the answers are all alphabetical. So there's no, like, don't try and out mind game me to guess the answer. You're not, we're all good test takers if we've made it this far. All right, what do we got there, Emily? Okay. So I like the fact that there's a smattering here. I also like the fact that the correct answer was the most common one here. About 50% of you got this right. This is artifact on both of these. Let's go back to this. All right, so on this, and this is super common also, that you will be called about this. So if we take the first strip here, the 2 AKG leads, you can see that there are QRS complexes marching through here. And the rate of this doesn't change from the second half of this strip to the first half of this strip. So if this was truly something like Flutter or atrial tachycardia here, at the initiation especially, you're going to get some irregularity, but the rate is also going to change. So, and also like the pattern here in the bottom one, you don't see a consistent pattern of whatever that artifact is. So this is like, you know, someone brushing their teeth or something like that. But this is super common. I get consulted for things like this probably about once a year. And I'm not on service every week. So happens multiple times a year for something like this. And we'll look at it and be like, yeah, that's artifact. The bottom one here, same sort of thing. There is a QRS complex that is marching through whatever this artifact is. And if you just sort of like take a step back and look from the balcony, you'll see that there is that QRS that just seems to be marching through whatever this other thing is. And that sort of is marching up with whatever the waveform is. But if this was, let's say, VT, you can't have a VT that's going at, let's just say, 300 beats a minute, but the pulse ox or arterial line or, you know, pulmonary pressure line, if you have a swan in, that rate can't be, you know, 1/4 of it. So use your ancillary data as you're trying to figure this out. Don't just go off of your EKG, but if you have those other things like the pulse ox that's simultaneous with it, to know, hey, look, this is probably something that's not a pathologic rhythm. It's probably artifact. It helps also to look at onset and offset. But again, try and, you know, especially if the patient's feeling fine and it just sort of seems odd that they would have something like that, think about artifact in your list of potential diagnoses. Let's talk about the wide complex thing. So a 35-year-old with a history of non-ischemic cardiomyopathy, and he presents with palpitations, and this is his EKG. So the question is going to end up being, what's the rhythm? I'm going to give you this, these two leads, lead 2 and V5. Look at that. Good work, everyone. 94% of you. All right, yeah, so this is VT. So first thing, just to be very clear about, this is VT. It's 114 beats a minute. We usually think about VT as like a life-threatening thing and you're going to die from it instantaneously or within a minute or two, a couple minutes, 10, 15 minutes. But you can have VTs that are super slow. And also you can have VT where the person is talking to you with a normal blood pressure. At the same time, you can have someone who is in rapid AFib with a blood pressure of 60/40 or Flutter or something. And so you don't want to use your hemodynamics to make your diagnosis for you. What helps you in this situation is, number one, they have a history of a cardiomyopathy. So anything like that, where they have a depressed ejection fraction, or maybe they're congenital heart disease or something where their heart is not normal, at least think a little bit higher in your differential that it's going to be VT. The key things on this EKG, I'm going to point out to you again the positive arrow sign. So this person has VA dissociation. The arrows are pointing at the P waves. So you can see a P wave here in lead 2. You can see this second P wave right before the QRS, right after the QRS. This T wave here is taller than the other ones because there's a P wave buried in it. And then on the downslope here, and so on and so forth. So there are more V's than A's. There are more QRS complexes than atrial signals. So that is one of the things that when you look at this EKG, and that would be the first thing that I would be looking for after I've decided that this is a regular wide complex tachycardia, is I'm looking for the P waves to try and see, can I find buried P waves or not? If you have 1-to-1 P waves, 1 V for every A, that makes it a little bit more challenging. The other thing with this that goes along with this being VT is that all the QRS complexes in V1 to V6 are negative. You'll hear the term, if you ever look up these algorithms, like there's the Bradycardia algorithm that people talk about SVT versus VT, about negative concordance. So concordance means that all of the QRS axes in V1 to V6 are the same, and they're all negative. Is another thing that goes along with this being VT. AVR being positive is not like a definitive criteria, but it sort of makes you think also that it's probably VT. Sometimes you will have people in VT and you will see things like this, a fusion beat. So with a fusion beat, you have a QRS that is looking wide everywhere here, but you have one beat here where it's more narrow. And that's because this is a sinus beat. It also happens trying to at the same time you have VT going. So it's a little narrower than otherwise seen because it's a mixture of some signal going down the Purkinje system, something, or the VT also going along. So it's a half of each. And so when you see something like that, that makes this likely VT. And that concordance out before. Here, all the QRS complexes in the record are positive, so that would go with this VT. See how fast this is, by the way, and we have a complete of it. So even though this person is in VT and they're going, I have to sit here and do the math, but 240-ish, give or take, beats a minute, we're able to get an EKG and they haven't passed out yet. So it's super helpful to me to have an EKG, a 12-lead EKG, especially if I'm going to be playing an ablation for this person. One of the things that you may also see with VT, and occasionally we'll see patients like this in the hospital where they get these paroxysms, and especially if it's this type where it's a left bundle branch block pattern and it's positive in the inferior leads. But you'll have people who have these paroxysms of what we might call non-sustained sinus rhythm because they have more VT than they do sinus beats. All right, so what do you do if you have someone who's in VT? So if they're hemodynamically unstable, do your ACLS algorithm, shock them. Again, don't shock someone who's awake, have anesthesia involved. If they're hemodynamically stable, please don't shock them. And again, don't use your hemodynamics to make your diagnosis. Don't say their blood pressure is normal, so it can't be VT. Call us in cardiology or electrophysiology. But if you're already on a cardiology service, what are you going to do? So you're going to give amiodarone, 150 milligrams IV, if you're talking about stable VT, and then you'll do a drip. If you need to, you might give lidocaine also. We have patients who are in a VT storm and we'll be using both medications. There's some data if their blood pressure is decent enough to be giving propranolol, propranolol specifically in people who have VT storm. And then especially if this is occurring in someone who is having a significant heart failure exacerbation, then we're talking about some sort of mechanical support. So whether that's something called an Impella, whether that's a balloon pump, IABP, intra-aortic balloon pump, ECMO we might be doing for some people. And then if someone is still having VT, then you really want to get rid of all of their sympathetic drive, or as much as you can. So then we're going to be talking about paralyzing people, but you don't want to paralyze them and sedating and paralyzing them. So you want to intubate them in that situation. And you're not necessarily intubating them for the pulmonary aspect of it. You're intubating them for the sedation and paralyzing aspect of it. And then there are some other fancy things that we sometimes will do in terms of sympathetic chain blockade and some other stuff. All right, super common. You will be called in the middle of the night for someone having PVCs. And so what are you going to do? Well, again, you're never going to go wrong with getting an EKG. But most times, if something, if the person is asymptomatic, don't do anything in the middle of the night. Please let the person sleep. If they're having symptoms, the first line for you would be a beta blocker, maybe verapamil you might give if they're symptomatic. You can check labs. I mean, here's the honest answer. You're going to check labs and they're going to come back as normal, but it's going to make you feel like you did something for the patient. It's going to make the team feel like you've done something for the patient. But most times these rhythms are not going to be triggered by like hypokalemia or something. Not always true, but most times. Turning off telemetry is probably the right answer for a lot of people. We have way too many people on telemetry, and we're picking up rhythms that aren't clinically significant and use up resources by having people on telemetry. But most times for PVCs, you're not going to do anything about it. All right, polymorphic VT. So if you have someone who's in polymorphic VT, and hopefully you're not having too many 12-lead EKGs of someone in polymorphic VT. So what are you going to do? So you're going to do your ACLS algorithm. You're going to shock them. You'll give them magnesium. Really important to get a 12-lead EKG when they're not in VT, because that helps you figure out what the diagnosis is. The two most common causes of polymorphic VT are going to be ischemia or long QT syndrome. And so you want to be calling us, and depending if it's ischemia or long QT, if it's ischemia, we're going to be giving a beta blocker. If it's long QT, we give isoproterenol, which is a beta agonist. We might put in transvenous pacing to increase the heart rate to try and suppress it. If we think it's ischemia, then we'll do an evaluation for that with an angiogram. If we think it's long QT, we're going to avoid long QT prolonging drugs. I'm just putting a push out there for this website, crediblemeds.org. It's also torsad.org. We'll link to this if you can't remember this, and there's an app for this. This gives you the list of all the drugs that have QT prolonging effects. So if you ever have a patient with long QT syndrome, which is actually pretty common-ish, 1 in 1,000 to 1 in 2,000 people, and if you're in the UW system, clearly we enrich our patients with things that are a little bit more rare here. You'll see these patients. And so you want to try and avoid any drugs that are QT prolonging. And even in hospitalized patients, we give a lot of medications that can affect the QT interval and prolong them. So you can always look it up on this website. All right, VF. So, then the question is going to be, wait a sec, this person's in VF. Why do you have a 12-lead of this? And so LVAD patients, if they don't have an ICD, but they just have an LVAD, we have a whole stash of EKGs of patients in VF with LVADs who may or not be feeling it because they have a mechanical heart. So this is VF. So in that situation, shock the person, do chest compressions, do your ACLS drugs, epi, amio, and typically don't bother getting an EKG, but do your ACLS thing. All right, in our last less than 15 minutes here, we're going to talk about slow rhythms, bradycardias. So sinus bradycardia. Sinus bradycardia is going to be super common if you have someone on telemetry and they're sleeping or they're resting. That's number one. Number two, Wenckebach. So type 1, Mobitz 1, also called second-degree AV block. With this one, what you see here is that you have a shorter PR interval, and then it gets a little longer, 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 and a dropped beat. And then shorter and longer and longer and longer. So things to know about this. Number one, the P wave, the P wave rate is constant. So there's not an irregularity in the P waves, which may make you drop beats depending, like if you get a blocked PAC. So you're going to look at this and you're going to be like, oh yeah, look, The P waves are constant, but the PR interval is lengthening, 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 and then it drops. And when I look at that, really the big thing I'm going to look at is I look at the dropped beat, the drop P wave, and then I look at the beat before it, and I look at the beat after it. And the beat before it, it's super long, and the beat before it is short. And you're going to see your greatest differential in your PR interval between those two beats. So I typically am not sitting there and looking at every single beat to see is the PR lengthening. I'm going to sit there and just look at the beat right before it drops, the beat after it drops. If there's a difference in the PR interval, then that is Wenckebach, Mobitz 1, second degree heart block, it's also called. That's going to be in contrast to this. Sorry, the black and white sometimes doesn't always come through as well. But if we look at this V1 here in the middle, we have a drop beat here. You have a PR interval that is fixed here, and it's the same on that as it is afterwards. So this is type 2 second degree AV block. Type 2 is more concerning that it's going to progress to complete heart block. Also, the fact that this person has a bundle branch block, so the QRS is wide, is making you concerned that their conduction system already has some disease below the, or in the His or below the His. And so that's going to make this more likely to be Mobitz 2. You will have people in 2-to-1 heart block. So here it is. You have P wave, QRS, P wave, nothing, P wave, QRS, P wave, nothing. You can't tell in the scenario if it's Mobitz 1 or Mobitz 2. And then you'll have complete heart block. So here it is. They are in complete heart block. They have P waves and QRSs that have no relationship to each other. Right, this PR interval here is different than this PR interval here. The P waves are marching out. The QRS complexes are marching out. I will say this, as an electrophysiologist, this is one of my absolute favorite EKGs, because the P waves are not getting down to the QRS complexes. The atrial signal is not getting down to the ventricle. However, what you'll see here on this beat, this P wave is negative, and on the first beat, the P wave is negative. So the reason for that is that the P wave is actually going backwards. So the AV node is not conducting forwards, but it's conducting backwards. And it's just really cool that the AV node can do that. So again, as an electrophysiologist, I find this EKG lovely and beautiful and such. Is there a chat question, Emily?
Yeah, there's a chat question. Ryan's asking, if the junctional beat is narrow versus wide, does that change any management points / urgency?
Yes, we're going to get to that in a second, in 2 slides. It is a great question, Ryan. The other thing just to throw out there is regularized AFib. So AFib should be irregular. But if you ever see someone in AFib and it's regular, then that could be complete heart block with a junctional escape rhythm. And the one situation where you're going to be most likely to see this on a medicine service is going to be digoxin toxicity. So dig toxicity has a bajillion different possibilities of arrhythmias, but one of them is complete heart block. The other situation where you will see this on a surgical service is post-cardiac surgery, that they get AFib post-cardiac surgery, and then they get heart block, depending on what the surgery is. But digoxin toxicity. All right, so bradycardia management. So usually what we're talking about is someone who has a heart rate of less than 40. And then the first question is, are they symptomatic? So are they having mental status changes, hypotension, angina, shock, heart failure, something that is making you really concerned? And is it acute or chronic? So is it, let's just say, sinus bradycardia, and they're a Tour de France cyclist? Pretty sure for most of them, their resting heart rates are probably going to be in the 30s. So you're not going to be worried if you see them and their heart rate is in the 30s, because that's what it should be. But if someone has a heart rate that was, 85, and then it's abruptly 35, then you're going to be much more concerned. Are they sleeping? And if you start to see bradyarrhythmias, even complete heart block while they are sleeping, I don't get concerned. I'm going to be asking, do they have sleep apnea? So the big thing we want to know is, are they, not big things, several big things that we want to know is, are they awake or not? And then getting to Ryan's question here of how do you know what you need to do? So first thing is, again, are they awake or not? And are they symptomatic or not? If they are symptomatic and if they're awake, then you're going to do something about it. But the question is, how acute do you need to do it? So one of the keys is, what is the width of their QRS complex with their escape rhythm, assuming, let's say, they have complete heart block. And if the QRS is narrow and they're feeling okay-ish, you do not need to put a temporary wire in. But if their QRS is wide, or if they're having significant symptoms because their heart rate is 20, then that's the situation you would do it. So if their QRS is narrow, it's usually from a junctional escape rhythm, and it's usually pretty stable. And it's going to be able to last them the day or two before they can get a permanent pacemaker. But if their QRS is wide, then you're going to be more concerned that it's an unstable escape rhythm, that they may lose that escape rhythm, and then you're calling a code and having issues. And so if it's wide, that's a situation where we typically say to put a temporary wire in. So if it's an acute situation, transcutaneous pacing is what you can use, but please sedate the person because it's really uncomfortable. And one of the things I would ask of you is, please don't say, like, leave pacer pads on the patient just to be safe. Because I did a research study a couple of years ago with a resident, who Emily may remember, Dan Nguyen, when he was here. So he and I looked at, do you ever use pacer pads when they've been put on the patient? And we never found a patient in the hospital where that was done. And it doesn't take that much time for most patients to put them on. And it's really irritating to patients. And they start to fall off after 24 hours. So please don't do that. You can give atropine, especially if it's sinus bradycardia. For the occasional cardiac transplant patient who has this problem, which you probably will never see, it can actually make things worse. But same thing, don't say atropine at the bedside. That's like a common thing. A lot of floors don't let you do atropine at the bedside. There is a concern that people may steal things or take things home. Like, you never know what patients or their family are going to do in the room. And it doesn't take that long to be able to grab atropine. And again, when we tried to look at this, we never found an example, at least documented in the chart, of atropine at the bedside actually having been used. You can give dopamine or epinephrine, or isoproterenol, but isoproterenol is actually pretty expensive to the hospital. If the person is having bradycardia because of a beta blocker overdose, glucagon is the treatment for that, and then transvenous pacing, like we were discussing a minute ago. So, in conclusions, you will be called frequently about arrhythmia issues. Get an EKG, look at tele yourself. If it is tachycardia, don't use your hemodynamics to make the diagnosis. And then again, come up with one of your boxes. Is it wide or narrow? Is it regular or irregular? And then use that to come up with your differential of what you think it is. Most times you're going to be safe using a beta blocker or a calcium channel blocker. If you're going to do something to try and convert it, amiodarone by far is going to be the #1 thing that you're going to end up using. Cardiovert if the person is unstable. If there's bradycardia, figure out where's the level of block? Is it in the sinus node? Is it in the AV node? Are they symptomatic? Are they sleeping? And then if you're concerned about them, please be calling cardiology, especially if you need to use transvenous pacing. So thank you. Please feel free to reach out if you have any interesting EKGs. I love EKGs. I love discussing EKGs. I love keeping them for my collection. So if you think it's interesting, that means it's probably going to be a good teaching EKG for other people in the future. So please feel free to reach out. If you have other questions now, I'm happy to take them.
Thank you so much. That was awesome. I'm keeping my eyes on the chat, and you guys can also unmute if you have any questions. I have a question. Do you have a good resource that you like for like practicing EKGs?
Yeah, I get that question. I'm trying to look at my shelf here. I think I've given away my books that have it depends on like how intense you want. I apologize. I'll have to look. Like, I have my list of that, and I just can't remember it off the top of my head of the books that I've liked in the past. I only have in front of me the books that are like challenging EKGs, which I'm sure the interns are not looking for right now.
Yeah, if anyone in the group has a source they like, just throw it in the chat. I know
Yeah.
Wave Maven is one people use. Oh
Yeah,
my.
there's like Marriott's is what I have on my shelf, but that's usually for like people who really love EKGs. There's the Dubin book, but if you guys don't know Dubin's backstory, you can Wikipedia him, and it's not a pleasant backstory, so I don't really like using that book anymore.
Well, thank you so much. Oh, go ahead,
Yeah,
Connor.
Connor.
Certainly, I have a question for you.
Yeah.
It's regarding stroke risk post cardioversion. Are there specific numbers that you could share about kind of what that risk is, or that increased risk compared to maybe a baseline person? I was just on UWARD service, and we had kind of a anticoagulate, bleed versus clot risk conversation with a woman who I think was admitted for hemoptysis, but then ended up going into AFib and got cardioverted. And she was like, I'm not taking a blood thinner right now that you're asking me to do, but we couldn't give her a number for like what her stroke risk would be. And I had the hardest time finding that. So do you have something on the top of your mind?
Yeah, great question. So that data is like 40 years old, just to know. And it really depends on what like their Chats-Duvasc is and things. But what I will tell people is it is up to a 5 to 10% chance of a TIA or a stroke in that first 30 days. The risk is highest in the first, 48 hours to a few days, but it's up to 30 days, up to 5 to 10%.
Okay, awesome. Thank you. That's just a helpful number to hang on to for me.
Yeah.
Okay, thanks.
Yep. Otherwise, stroke risk in someone who's anticoagulated or you do a TE, the risk is going to be 1% or less. And then in a person like that, I don't get into like, Watchman and other devices, but in that setting, you're not going to put it in acutely, something called the left atrial appendage occlusion. So, all right. Thank you, everyone. I got to head out also. Y'all take care. Good luck.
Awesome. Thanks again.
Thanks.
Bye.